Bismillah ar-Rahman ar-Rahim. Today we are going to talk about bone tumors. Our goals for this lecture are to know how to evaluate the patient, to understand the basis of classification, to know the principles of management and different methods of treatment. Introduction: tumor and tumor-like lesions and cysts are considered together, partly because their presentation is the same and management and classification. Benign lesions are quite common. Primary malignant ones are fortunately rare. Bone compromise of 75% of the average body weight. Neoplasm represent less than 1%, thanks God, of all adult and 15% of pediatric malignancies. What are the risk factors? Actually, there is no single cause that could be blamed in most patients. However, there are some risk factors. Those are previous radiation, exposure to chemicals, and genetic cancer syndromes, and immunodeficiency, barrier injury, such like scars, burns, chronic tissue irritation, foreign body implants, lymphedema, neurofibromatosis, Beckett disease, and bone infarct. Classification. Most classification of bone tumors to benign, classifying that to benign and malignant one. And this is a type of classification are based on recognition of the dominant tissue and products of proliferations or proliferating cells. So which cells are dominant, then accordingly the classification will be. If the dominant cells are osteoid, then it will take the name. Bone consists of cartilaginous, osteoid, fibrous tissues, bone marrow elements. Bone sarcomas are usually classified according to the type of the matrix production. If it is producing osteoid, then the name will be osteosarcoma. If it is chondroid producing tumor, then it is chondrosarcoma. If it this is provided it has a malignant cells in it, because we cannot say this in general, as generally speaking, because sometimes there is osteoid, but it could be benign, chondroid, but it could be benign. So chondroid, osteoid with malignant cells, then it will be sarcomas and malignant tumor. Here is histologic type, different histologic types, and what we call it if it is benign or malignant. If it is chondrogenic in type, it could be, if it is benign, osteochondroma, chondroma, chondroblastoma, or chondromyxoid fibroma. And the malignant type from the chondroid could be reticulum cell sarcoma, primary chondrosarcoma, secondary chondrosarcoma, dedifferentiated chondrosarcoma, or mesenchymal chondrosarcoma. So you see here, it depends on whether there is malignant cells beside the bony matrix. Is it chondroid? Is it or bony matrix like osteoid or chondroid backgrounds or matrix? And if you go through this for osteogenic unknown origin, you can see same. For benign, it has type of cells. If it is just benign, or what could be the malignant counterpart of it. But this type of classification has some drawbacks. What are that drawbacks? Most pervasive tissues is not necessarily the tissue of origin. This means that the most pervasive tissue It could be another tissue rather than the original tissue. So this is one of the problems. No pathological or clinical connection between the condition in any particular category. So osteoblastoma, osteoid matrix, osteosarcoma, they are different identity. No relationship between benign and malignant lesion with a similar tissue as osteoma or osteosarcoma, as I mentioned. Some tumors named as single entities like osteosarcoma, but in fact it is a family. Family compromises of several lesions with different behavior patterns. So basically there are differences between sarcoma, and when we say sarcoma we mean bone tumor or soft tissue tumor, something coming from mesenchymal cells, and carcinoma, something coming from epithelial cells. We know that the originator for bone, for fibrous tissues, for vessels, for soft tissues, for fat, all are the mesenchymal cell. So any tumor derived from that, we call it sarcomas, soft tissue sarcomas or bony sarcomas. While carcinoma, the background is epithelial cell, like CA stomach epithelial cell, CA thyroid, and CA renal carcinoma. So that's one of the differences. Other differences between sarcomas and carcinomas, if we go back to the histology, we will find what I said, epithelial cells and the mesenchymal cells. But even the way of spread, the sarcomas is spreading through blood, and carcinoma could spread through lymphatics. This is not a general rule, because we have some types of sarcoma, such like synovial sarcoma has the ability to spread through lymphatics also, besides they spread through the blood. And the third difference, that their way of pattern of growth. Carcinoma, it tends to grow from outside in, what we call it centropetal, from outside in. And this is why we could find invasion of blood vessels in carcinomas. While sarcomas, it grows in centrifugal, from inside, and it goes outside, مركزي, centrifugal. So it starts from the medulla within the bone, then goes to the cortex, then periosteum, then the soft tissue, then it the blood vessels. And this is very important when we do resections, because we can preserve the nerves, the blood vessels. What about the presentations in sarcomas? Actually, patient comes to you with one of those, either pain or mass, incidental X-ray finding, or neurological manifestation, or pathological fracture. What are the causes of pain in tumor? Causes of pain: rapid expansion with stretching of surrounding tissues, central hemorrhage or degeneration in the tumor, and incipient pathological fracture. However, even a tiny lesion may be very painful, such as an osteoid osteoma. An osteoid osteoma, the significant part in the history that it has pain that relieved by non-steroidal anti-inflammatory drugs. What are the causes of night pain? Night pain causes due to tumor, due to interleukin-1 and the inflammatory markers that causes night pain. But go and read more about that. from history, you have to dig deep in the history in order to know whether there is prolonged history. This may result in delay in treatment, and if there is other lesions rather than single lesion. So it could be multiple disease like multiple myeloma, and primary lesions maybe before that, and could give you clue that if patient has CA breast and then presenting with pathological fracture, it could be metastatic from CA breast. So primary lesions that been have surgery before for breast like mastectomies. So what happening now could be secondaries, and previous operation for the same side of the tumor with the new growth. Could be diagnosed as recurrence of the same tumor. And if there is minor trauma, we know that long bones and very strong bone like femur in young person could not be fractured easily. It needs high energy trauma. But if the patient comes to you with minor trauma, and this is cause pathological fracture, so could be due to already existing pathology at that side of femur before it tends to get fracture. And if there is positive family history, because in the risk factors, genetics have a role in tumors and inborn tumors, or previous radiation. Sometimes some tumors, soft tissue tumors, we give radiation if radiation was not accurate and the dose was high, and could cause what we call it radiation-induced sarcoma. Age may be a useful clue, and Ewing sarcoma and osteosarcoma occurs at childhood and adolescent, while chondrosarcoma and fibrosarcoma occur in the 4th and to 6th decades. And myeloma seldom seen before the 6 decades and should be anticipated within 40s or after 40-year-olds. In patient over 70-year-old of age, metastasis is common than all primary bone tumor together. And actually, we think about METs or multiple myeloma in any patient after 40 or 45 years old. So this is very important. Here is, you see here, there is age map for the tumor. Eosinophilic granuloma occur between 0 to 5 as benign tumor and unicameral bone cyst, and malignant leukemia, neuroblastoma, this is occur between less than 5-year-olds, and you see 6 to 18-year-olds for the malignant bone tumor, Ewing sarcoma and osteosarcoma, and above that is Ewing sarcoma, and metastasis above 40, and multiple myeloma as malignant bone disease. On examination, we do our examination as examining a lump. So there are some questions should be answered. Where does it arise from? Is it arising from bone or soft tissue? And if it is arising from bone, which type of bone? Is it femur, tibia, and which side of bone? Is it metaphysis or epiphysis, or epiphyseal or diaphysis? So where does it arise from? And is it discrete or ill-defined? Is it the discrete lesion? Is it ill-defined lesion? Is it soft or hard? Is it pulsatile or not? Is it tender? And if there is special test like sleep sign, which is significant test for lipomas, and some tests, special tests like transillumination tests, if there is any fluid inside that lump. And if tumor is near the joint, also we need to assess whether there is any fusion and or limitation of movement. And if tumor in spinal lesion, muscle spasm will take place, and back stiffness, painful scoliosis, compensatory will occur. And examination should also examine for symptomatic part, and don't forget lymphatic drainage. If there is any lymph involvement, lymph nodes involvement, you should detect and document that, and examine for the pelvis, abdomen, chest, and spine, since could be metastatic tumor from carcinomas. And don't forget also to examine for the distal pulses and the joint above and below. Investigation, we had a pre-biopsy investigation such as imaging and lab studies and the biopsy itself. The pre-biopsy investigation that should be done before doing the biopsy is plain X-ray, CT scan, MRI, and those should be finished before you go for biopsy, because you don't want to disturb the anatomy by doing your surgery for biopsy before doing the MRI and other images, in order to know the extent of the tumor. And bone scan also is very important, angiography in special cases, and X-ray is of paramount importance. It is still useful, and X-ray alone can seldomly be relied on for definitive diagnosis, but there is some exceptions. In some cases, it is a pathognomic, and it could be diagnosed by X-ray, like non-ossifying fibroma, and no need to go further for other investigation. Osteoma, sometimes in osteoma, you need to do CT scan in order to see the nidus. And osteochondroma, X-ray is enough. And here is questions that you need to ask for for yourself when you are reading the X-ray. On the left side, the two images are for osteosarcoma. On the right side are for benign lesions. You see the differences between the benign and the malignant, that the zone of transition here, the zone of transition between the abnormal and the normal is hazy. Here is hazy, but here is well defined lesion with well-known borders, and there is a sclerotic margin surrounding that. And also here same. So this is benign. When you see there is narrow zone of transition, this is goes for benign. Wide zone of transition goes for malignant sarcomas. So what are the questions should come into your mind when you are reading X-ray? The questions are: is the lesion is solitary or multiple? What type of bone is involved? Where is the lesion in the bone? What type of lesion? Is it has any center of calcification? Is it calcified at the center? Are the margins of the lesion well or ill-defined? What we call it the zone of transition. Is it narrow or wide? Wide zone of transition or narrow zone of transition? Narrow zone of transition goes with benign. Wide zone of transition goes with malignancies. Is there intra or articular extension within the joint? Is there cortical destruction? Is there any bony reaction? And this is for plain X-ray. And also the periosteal reaction has many types, like onion peel, what appear here with layers, like the layers of the onion when you cut it through. And here is sunburst appearance of reaction, like here. And here is Codman triangle. Codman triangle. This is different type of periosteal reaction. And here is some benign lesions. How does it act to the bone? The solitary, the first one on the left, solitary bone cyst, upper limb metaphyseal fracture, then aneurysmal bone cyst. It starts from the metaphysis, expanding eccentrically, not equal. It goes to one side, and the fibrous cortical defect. It is just occupying the cortex, and fibrous dysplasia, expanding ground glass appearance. You will find there is what we call it ground glass appearance. You cannot see behind, just like you see some shadow in the area, as if you look for something behind is not clear. So this is ground glass appearance. And chondroma with calcification, flecks of calcification, and chondromyxoid fibroma eccentric, dense endothelial margin. Chondroblastoma, this is the only epiphyseal tumor, and it could extend from the epiphysis into the metaphysis at late stages. And the giant cell tumor, this mature bone, always extend to subarticular margin. It starts from the metaphysis and go to the epiphysis, so it is epiphyseal. And the last one here is brown tumor. Think of it. Look for signs of hyperparathyroidism. CT scan also is important because intraosseous and extraosseous extension could be detected by CT scan, cortical erosion and fractures. And the important thing for CT scan lung is to detect whether there is any pulmonary metastasis, pulmonary nodules in the lungs, which is appear at the periphery. And this is suspected lesion in the inaccessible sites. Also, UCT is useful in that. And response of the chemotherapy could be also assessed and followed by the CT scan. Radiofrequency ablation for some tumors, benign tumors like osteoma, could the nidus could be dealt with radiofrequency ablation. And also CT scan is useful in guided CT biopsies for biopsies that taken from site is like pelvis, which is difficult to access in some cases. Detecting nidus in osteoma, nidus will appear very obviously in CT scan rather than the X-ray. Here is a CT lung with lung window, and it is normal. There is no lung metastasis, and MRI actually is very important, especially in malignant bone disease. And we assess through the MRI the spread within the bone into the nearby joint, into the soft tissues, blood vessels, and perivascular space, and if there is any skin lesions. Here is the MRI, which has many sequences and has many different planes, so it is multiplanar, multi-sequence, and non-ionizing, and could be used safely within the pregnancy, especially after the first trimester. And here has coronal and sagittal and axial. You have to see all that. The coronal one, like one in the image in the left side of the screen, and in the middle of the screen, the sagittal one, and on the right side of the screen, the axial images. And those give you the extension of the tumor intramedullary and through the joint and or epiphysis, and if there is anterior or posterior extension in the soft tissues, and whether there is encasement of the blood vessels, especially if you give a contrast in T1. The bone scan, the 99 technician, we use it, but it is not non-specific reactive changes in bone. It can detect that, and a small amount that does not show up clearly on X-ray. Escape lesions could be seen also in bone scan, but the best could be seen in MRI. And escape lesion is a lesion that from the malignant bone tumor maybe within the same, it should be within the same compartment. If there is distal femur osteosarcoma, then we are expecting and fetching for escape lesions at the proximal femur within the same compartment. It is considered as a discontinuous tumor or lesion from the same tumor. And silent secondary deposits also could be detected in radionuclide scanning or bone scan, and give examples of If you want to give examples of bone tumors with negative false bone scan, actually in Ewing sarcoma, and the most famous is multiple myeloma. When we do multiple myeloma, we will get negative, there is nothing, but this is false, because if you do skeletal survey, x-rays, that you will find many lesions. But because that lesion not making reaction with bone, new bone formation, it doesn't be detected on bone scan. So multiple myeloma, if you did a bone scan, it will appear like negative, but this is considered as false negative. Here is image of bone scan, and there is a tumor around the left anterior femur. Sorry, on the right, on the left anterior femur, actually there is a tumor in the distal femur, and that is the only single lesion. Laboratory investigations actually is very important. The blood tests are often necessary to exclude other conditions such as infection, metabolic bone disorders, and brown bone tumor and brown tumors, such as increase of the hyperparathyroidism, and blood tests also useful in detecting anemia, increased ESR, elevated serum alkaline phosphatase, and serum potassium, calcium, albumin. And protein electrophoresis may reveal an abnormal globulin fraction, and urine may contain Bence-Jones proteins in patients with multiple myeloma. A raised serum acid phosphatase suggests of prostatic tumor. What are the differences or significance of the biopsy? What are the significance of biopsy, and what are the indication for biopsy? The significance, in order to confirm the clinical diagnosis, you need to do a biopsy and accurately classify the lesion, because the classification depends on two pillars. First of one, the anatomical spread, and this is we get it through the images that we do, like X-ray, MRI, and CT chest and bone scan. And the other pillar is histological grading, and this is we can get it by doing a biopsy and get histological report on it to know the aggressiveness of the tumor, and then we can classify the tumor according to the Enikin classification, as we are gonna to discuss a little bit late. Indication for biopsy: the benign aggressive lesions is indicated for biopsy, such as giant cell tumor and malignant tumors and questionable lesions. You need to know whether is it or benign or malignant or infection, or so better you go and take a biopsy. Biopsy, it should follow a full assessment and imaging. You consider that after you do your full assessment, you do your images, and then you do your biopsy. Your biopsy either closed type or open type. The open type is excisional biopsy. If you are deadly sure that it is benign, then you go for excisional biopsy. If you are not sure, then you go for incisional biopsy. But that was the standard before going for closed type of biopsy, and this is the closed type of biopsy is considered now as good type, giving good enough tissues, especially if done properly. And closed type contain core type of biopsy by core needle, Jamshidi needle, or true cut needle. And the fine needle aspiration actually is not good for bone sarcomas. Maybe it will be of good and could be rely on carcinomas, because it cannot give you a clue about the matrix. How to plan for biopsy? You need to put your position of the point of entry along the planned incision of definitive surgery. So if it is malignant bone tumor, when you do your biopsy, you put in your mind, is it the same line with the definitive surgery that will be done in the future or not? Because you need to take that tract of biopsy, which is considered potentially contaminated. So you put your biopsy within the anticipated expected line of incision for the definitive surgery in the future. And here is a picture of osteosarcoma with osteoid cells under microscope of histopathologist, and staging of the lesion. It depends on graded on their cytological character, clinical behavior, spread and recurrence. And why we do staging? Because by that we estimate the prognosis of the patient, formulation of the rational strategy for treatment, and staging the lesion. For benign lesions occupy the lowest grade. They are usually amenable to local excision, little risk of recurrence with marginal excisions. And staging of the sarcoma, low grade, only moderately aggressive. Metastasis is less than 25% and take a long time to metastasize, primarily chondrosarcoma or proosteal osteosarcoma. High-grade tumor, for example, like osteosarcoma, the conventional type, usually very aggressive and metastasize early. And local spread, intracompartmental spread, and confined to an enclosed tissue space. Extracompartmental spread, this is intended to enter into facial or extrafacial planes with natural barriers to proximal or distal spread. To understand this slide, intercompartmental, if there is a tumor within the bone, the femur, and it's spread within the femur, within the medulla, just inside that femur, this is considered as intracompartmental. But if it is breaking the cortex and goes to the proosseum and the soft tissue, then fibrous tissue, the muscles, goes outside from bone, this is considered as extracompartmental. It goes from one compartment, which is the bone, to another compartment, the soft tissue surrounding that bone. So bone, joint cavity, muscle group within the facial envelope should be looked for any spread, local anatomical spread. Staging, we use Anakin classification, and this classification, as I said, it depends on two pillars: the histological grade and the side of the tumor with the spread, anatomical spread. So if a tumor within the bone, this is considered the site of the tumor originally, and metastasis if there is soft tissue and lung metastasis, and the grade is high grade. So that's very important for diagnosis. So it needs the two pillars: histological grade, and 2 and 3 we consider as a component of the second pillar, the anatomical spread. Staging, anything staging system was tested retrospectively on 379 actual cases of bone and soft tissue tumors, showing that prognosis varied with the stage. The system aid in assessing prognosis and planning for management. Applies to lesion of connective tissue, not primarily lesion of round cell tumor. Example for leukemias, lymphomas, and myeloma. Cannot be applied in leukemias, lymphomas, and myeloma. Here is the Anakin classification. We have stage 1, stage 2, stage 3. In stage 1, all low-grade sarcomas, like chondrosarcoma, when we take a biopsy under microscope, it appears like low-grade. So that if the low-grade within the bone, within the femur, this is considered intracompartmental. So it take A, type A. Any type A means intracompartmental. That tumor is still within the bone. But if the bone breach and the tumor goes to the soft tissue, then that will be labeled as type B with extracompartmental. So chondrosarcoma has bony origin and breach the cortex, goes to the soft tissue. This is considered type 1, stage 1B, 1B, 1 because it is low grade chondrosarcoma, and B because it get out of bone to another compartment, so it is type 1B. And for stage 2, any histologically high grade, such as conventional type of osteosarcoma, which considered as high grade. We know that there are many osteosarcoma else rather than the conventional type, could be of different grades like low grade, but the standard conventional osteosarcoma is considered as stage 2 as high grade tumor. And if that distal femur was diagnosed as osteosarcoma and that tumor was just within the bone, so it will be labeled as type 2A. And if that tumor breach the cortex, break the cortex, go to the soft tissue, and this is will label as type B. So it will be stage 2 because it is high grade conventional osteosarcoma 2B, and it has a breakage of the bone and goes from this inside the bone into the soft tissue. And stage 3, it is for any sarcomas which have metastasis to the lung or distal metastasis. Any distal metastasis, this is accordingly will be stage 3. So it is easier. This is the Anakin classification with that 2 pillars. The grade, you need to know the grade through the biopsy, and before that, you need to know about the local and distal metastasis, and this is could gain that information from the images such as X-rays, MRI, and CT scan and bone scan. Example, as I said, osteosarcoma considered as high grade, so it is type 2. If it is within the bone, A. If it is outside to the soft tissue, it is B, so type 2A. If it is confined to bone, and type 2B if it is spread to the soft tissue, and if it has pulmonary metastasis at the time of diagnosis, so it considered as Anakin stage 3. And this is 2B means high grade because 2 is high grade, and B is extracortical or extracompartmental, as we said. So this is for Anakin classification. And the type of management we can do for tumor, either radical resection, as you see here. We take all the compartment, like when we do amputation, disarticulation, if the lesion here, and or wide local excision. This is for malignant bone tumor. The other two, we just reserve it for benign tumors. We cannot do intracapsular excision, the marginal excision. This is done for benign lesions, but malignant lesion, because if we do that, this means we go through the lesion, and this is not the concept regarding the malignant sarcomas. And the marginal excision and the intracapsular curettage, like curettage, we cannot do it. So the curettage or intracapsular excision, it means curettage, or marginal excision, this is left for the benign lesion. But malignant lesion, our options are either or, either wide local excision or radical resection, because the principle that you should know about osteosarcoma and even sarcoma surgical type of operation is wide local excision or radical resection. The definition of wide local excision, that we take the tumor as in block with normal tissue in all direction, bone in normal bone in one direction, normal muscles in other direction. So you take the tumor without opening the tumor, without looking for the tumor. The tumor options of excision is intracapsular, intralesional, this is what we mean by curettage, and marginal excision, the first and second, those left or just for benign tumor. Malignant tumor, you should do either wide excision or radical resection, as I show you in the image on the left side of the screen. Here is example of one of the cases that we did wide resection for the distal femur osteosarcoma and replace it by endoprothesis metal, and we preserve the blood vessels as you see here. And methods of treatment: tumor excision and lip sparing surgery. The method of treatment: either tumor excision, limb sparing surgery, multi-agent chemotherapy, and radiotherapy. Actually, in osteosarcoma and Ewing sarcoma, our treatment is chemotherapy, then neoadjuvant chemotherapy, then surgery, then adjuvant chemotherapy. And in some cases, we add radiotherapy, especially for Ewing sarcoma, which is sensitive for radiotherapy. The Ewing sarcoma is sensitive, but the osteosarcoma is not sensitive for radiotherapy. Ewing sarcoma is sensitive for radio and chemo, and the osteosarcoma is only sensitive for chemotherapy, while the chondrosarcoma is not sensitive for radiotherapy or chemotherapy, unless it is just palliative, used as palliative treatment. Here is example of case with also osteosarcoma, and this is actually the case also of endoprothesis that done. So this is the end of our lecture. Thank you for following me during it, and I hope it was well explained. Thank you, and all the best.